What brings us here? To this place with the coldest winters and hottest summers? We don't come here to retire. We come here to live, to be challenged, to be inspired. This is a city that demands fresh thinking and duly rewards it. If you can make it here, well, you know what they say. We New Yorkers, we're always pushing ourselves to be better. No wonder this city gives us the best of everything. You don't have to look far to see it. It's all around us. The best food, the best music, the best medical care, the best train station. At NYU Langone, we're collaborating on every level to be the best we can be for New Yorkers and for everyone who seeks our care. After all, we're New Yorkers too.
Hello, and welcome back to Women's Health Watch, a show brought to you by NYU Langone Medical Center. I'm your host, Dr. Eva Kosta. I'm a cardiologist at the Joan H. Tisch Center for Women's Health at NYU Langone Medical Center, and I will be coming into your homes every week to talk to you about your health. Today, in particular, we're going to talk about the heart. With me today is Dr. William Tenet. Welcome to the show. So happy you're here.
I'm very happy to be part of you tonight.
An important topic that we're going to discuss today is coronary artery disease. Most of us don't realize that we will probably die of heart disease. So with Dr. Tenet today, we're going to discuss what is coronary artery disease. People hear about atherosclerosis, hardening of the arteries, coronary artery disease. What is that?
Coronary artery disease is really, to use a layman's term, hardening of the arteries, and that is caused by atherosclerosis, which is caused by deposition of cholesterol plaques in the main arteries of the heart. And of course, it can occur in any of the major arteries of the body to the point where, as it progresses, it can then cause a very significant stenosis, to use a Greek term, just like atherosclerosis is a Greek term. And everything we'll discuss today comes from the Greeks. A stenosis in the coronary artery, or blockage in the coronary artery, if it becomes significant enough, can lead to symptoms and ultimately can lead to a heart attack.
But there are young people who only, let's say, have 40% stenosis, who can have plaque that's unstable, which I'll ask you about later, who can have a sudden heart attack, and those people are at greatest risk of dying, correct?
There's no question about it. The old teaching when I was in medical school, and maybe even when you were in medical school, was that we were worried about the 90% or the 95% blockage that very often is very heavily calcified. Mm-hmm. It's like an eggshell around the cholesterol plaque, and that eggshell, that calcification, really prevents it from rupturing. It's the rupturing of a mushy plaque, which can be that 40%
Just
plaque.
Just the 40% young person's plaque.
Which therefore can lead to a whole other sequence of events that occur at the vessel wall that can therefore lead to a very quick propagation of a thrombus, which is a clot, mm-hmm. and thereby closing off the artery completely, which ultimately causes a heart attack. So you're right. We are concerned about the 40% vessel. We may not be as concerned about the 90% vessel that's calcified, but that calcification, as you well know, can very often serve as a surrogate marker. And
yes,
that's
and
why
we could talk about calcium scores later.
That's why calcium scores sometimes can be very important.
So, and heart disease is prevalent. Most of us, if we live long enough, are going to die of heart disease. I mean,
well, there's no question. It's still the leading killer in the United States of men and women. Approximately 400,000 people a year die of coronary artery disease. If we take the statistics worldwide, 7 million people die of coronary artery disease worldwide. And that's up, in fact, from 1990, where it was only 5 million. So despite the progress we have made, it's still the major killer in the United States, and it's a major killer worldwide.
So why do you think that it's gone up? Do you think it's diet? Do you think it's stress? Why do you think the incidence is going up?
You know, that's a great question. I think that it's probably a combination of all of the above. There's no question that the dietary habits of Western society has led to an obesity epidemic. It's not only obesity, it's where your obesity is. And quite
frankly,
stomach
versus derriere.
Stomach versus derriere versus thighs. Dr. Tenet is getting it around the stomach, so
No, and you're thin in person. I should tell people when they look at you on camera, thin in person.
But we worry about that because, as you know, the distribution of the fat in that region leads to a highly inflammatory state. And when we talk about coronary artery disease or atherosclerosis or hardening of the arteries, we're not only talking about cholesterol, we're also talking about the inflammatory component. And now we believe that inflammation plays a very significant role.
And then it's not just the arteries of the heart, as you pointed out. It could be the arteries to the brain, the carotids. It could be the aorta, the aneurysms. It's a systemic.
Absolutely. It's not confined to one organ system. So, you know, when we see a patient with coronary artery disease that we've diagnosed, we are very conscious about potentially screening their carotid arteries, screening their abdominal aortas, which can develop hardening of the artery and expand and form an aneurysm. And very frequently, these patients also have peripheral vascular disease that impedes their ability to walk. So it is a generalized process. It's a systemic process. It's just not confined to one organ.
Right, so if you have one, you should really look for the other.
Absolutely.
So for the audience to know, what causes coronary artery disease? What are the risk factors?
Well, there's no question that cholesterol still is the primary risk factor.
And that would be the LDL.
And that would be the LDL.
Or a low HDL.
Or a low HDL. Unfortunately, it is much clearer in the high LDL versus the low HDL because we're finding out that not all HDLs are the same. Mm-hmm. But there's no question that a high LDL is a driver. And the LDL is the bad cholesterol, is the driver for hardening of the arteries. Smoking is a
terrible.
major risk factor. But it's not only smokers, it's also secondary smoke. There's no question that secondary smoker, for instance, I saw a patient the other day who had a fairly significant heart attack. He's doing extremely well, doing everything he's supposed to do, stop smoking, but his wife continues to smoke. And it's that secondary smoke that can be really catastrophic in a patient like this. And if we look at the statistics, on all the smoking bans, for instance, that we have now, the incidence of heart disease has dropped more significantly than the incidence of lung disease since we banned smoking in public places. So that really reflects the importance that secondary smoke plays. So a smoker and secondary smoke have a real impact on coronary artery disease. Diabetes.
Diabetes, big one.
Is a big one. And as you know, and as everybody in the audience has been reading in the papers, type 2 diabetes is in epidemic proportions in the United States. Family history. Genetics is a very, we cannot escape our genes. And in patients that have a strong family history of heart disease, specifically families that have developed heart disease at a relatively young age, we are more aggressive in screening patients, even at a young age, to make sure they don't have that predisposition. And finally, high blood pressure. High blood pressure plays a very significant role as well. So it's cholesterol, diabetes, high blood pressure, family, and smoking. Those are big five. And I think I'll probably add the postmenopausal state, which you are.
I'm not there yet, but
I
will be, God willing.
But are aware of it in the Women's Center.
Yes.
And I think that one other that is not necessarily established as an established or organized risk factor is the role of sleep apnea, that has a significant role, we now believe, in heart disease as well.
But in menopause, women should be aware that their HDLs will drop,
right.
Their LDLs will go up, because once the estrogen drops, your hormones, the hormone they make your lipid profile more favorable.
Absolutely. Not only that, as they become postmenopausal and enter the postmenopausal state, there's a higher incidence of high blood pressure, and there's a higher incidence of central obesity in females.
Prediabetes.
And prediabetes. So the postmenopausal state, or even the
perimenopausal state, which is in your late 40s, early 50s,
is very important. So we are paying, much closer attention to those patients, especially females in the perimenopausal state. And despite the technological advances we've had, and I have this discussion every day with medical students, which I'm sure you do as well, we rely so heavily on technology, but sometimes we don't take a very good history. Mm-hmm. whether a patient has had gestational diabetes or toxemia of pregnancy. All of those factors may place them at a higher risk down the road for developing heart disease.
That's true, yes. So what about, so let's talk about now the warning signs of heart disease. What are some symptoms people should pay attention to?
Well, there's no question that the classic symptoms is a pressure in your chest. It can very frequently radiate into the jaw, into the throat, into the teeth. I've had patients that felt that they had dental problems and went to see a dentist because they were having tooth discomfort or jaw discomfort, usually occurring with exertion. Very frequently, it can be very subtle. It can just be, I just get short of breath walking up that hill or climbing up that stairs, which didn't happen to me a month or 2 months previous.
So interruption in the patterns so people's regular patterns are interrupted
You're
by some
absolutely
symptom.
right, and the change in pattern is extraordinarily important. It's not so much the symptom per se, but the change in pattern. It can be very, very subtle. But we look for a change in exercise capacity because it usually manifests itself with exertion. And then as it progresses, it can manifest itself at rest as well.
I tell my sedentary patients it's hard to detect heart disease in them because they don't move, they don't exercise. It's the ones that move that can tell you, I can still go up 5 flights of stairs and not have chest pain, or they'll tell you I go up, but I'm more short of breath. So the more active people, you can detect heart disease easier.
And sometimes it's very difficult to differentiate heart disease or the pain of heart disease. And most patients, as you know, don't necessarily describe it as pain. They describe it as a discomfort of heart disease.
Or can't describe it.
Or can't describe it. Or it just feels weird, or it just feels like there's a pressure on my chest. There's an elephant sitting on my chest. And if you take a careful history, if those symptoms occur with exertion and they occur with shortness of breath and with sweating, you're really worried about that patient. On the other hand, if I have a patient that has a chest discomfort and is able to walk 5 miles a day or exercise 2 miles a day and has no symptoms, it makes it less likely. It's not to say we're not going to investigate it further, but it does make it a little less likely.
So, men and women do have very similar symptoms, but they also have different symptoms. And I'm going to ask you, you live with 4 women, a wife, 3 daughters, and a female dog.
And a female dog.
And you're very sensitive to women's issues and
health. I'm a blessed man, but very sensitive.
You are good. So let's talk about some differences between men and women in terms of symptoms. They can all get chest pressure, they can all get short of breath, but they can also have the more
It could just be fatigue.
Fatigue, very big one.
Fatigue is a big one. It could just be some minimal shortness of breath, or I just don't feel right. I just know something's wrong and I just don't feel right. It could very frequently be symptoms that they think may be gastrointestinal in nature. So it's not that crushing chest pain necessarily, but we also know that the pathophysiology, or what we see in women, may be very different. In other words, when men have heart disease, the blockage usually occurs in the large arteries, which we call the epicardial arteries, the major arteries of the heart. Women, in fact, may have heart disease in their smaller vessels that we can't even visualize with an angiogram, and can have what we call coronary flow issues, flow reserve issues, the resistance, the small resistance vessels of the heart, not necessarily the large vessels that we can visualize. Another entity, speaking of women, that we have seen in women and I have not seen in men is the broken heart syndrome.
The octopus trap heart.
Right.
Takotsubo.
Women that have been under extraordinary emotional stress, either through the death of a loved one.
An argument.
Or a bad argument, or something tragic happened in the family, develop a heart attack. And yet when we do an angiogram, which is the best way we have of determining whether they have any significant blockage in the major arteries of their heart, we find the arteries are clean, suggesting that there may have been an element of vasoreactivity, where the vessel becomes a little more reactive and can shut down in the absence of a blockage, or we're dealing with smaller vessels that develop vasoreactivity and interrupt the blood flow to the heart muscle, and therefore they develop a heart attack.
And that we think is from the stress hormones, the adrenaline.
No question.
Right.
No question. So women, and unfortunately, they have a worse prognosis. Women having a heart attack don't necessarily do as well as men.
That's true.
So one of the reasons I'm wearing a red tie today is not because it's Heart Month. It's also for our recognition of women and heart disease, and that as a male cardiologist, I need to be more sensitive to women. And as you know, studies have shown historically, I think it's changing now, that we have not necessarily treated women as aggressively as we've treated men in the past.
Well, now women are advocating for themselves, so
as
that's
they
good.
well should.
Yes, yes. So we're going to go to a quick commercial break, and then we'll be right back with Dr. Tenet.
More than 8 million people live right here. 27,000 of us for every square mile. That's a lot of people. What makes this city such an attraction? What makes this place so cool? We take pride in saying, I'm a New Yorker, and that's the way it's always been. One thing we've all learned in recent times is that no matter what life throws at us, we face it together, and we always come through, stronger than before. We are, for the most part, good people. We come to the aid of others, willing to lend a helping hand because we care. Even though we sometimes get the impression we don't. At NYU Langone, we're here to care for our fellow New Yorkers and for everyone who needs us. That's what we do. That's what we love to do. What brings us here? To this place with the coldest winters and hottest summers? We don't come here to retire. We come here to live, to be challenged, to be inspired. This is a city that demands fresh thinking and duly rewards it. If you can make it here, well, you know what they say. We New Yorkers, we're always pushing ourselves to be better. No wonder this city gives us the best of everything. You don't have to look far to see it. It's all around us. The best food, the best music, the best medical care, the best train station. At NYU Langone, we're collaborating on every level to be the best we can be for New Yorkers and for everyone who seeks our care. After all, we're New Yorkers too.
And welcome back to Women's Health Watch. Today we're talking about heart disease with Dr. William Tenet, and that was a great conversation, thank you. So let's talk a little bit about, there's so many things to cover. We were going to talk a little bit about diagnosis or how we screen people. You know, we're limited by insurance, but what are some general screening tools that we use?
I think that cholesterol levels are extraordinarily important, especially in a patient that may have a family history of heart disease. And as you probably know, we're starting this cholesterol screening in younger people now, even in the pediatric age, because we do know that the fatty streak, or the early deposition of cholesterol in the artery, can occur at a very young age, even, you know, after birth, for that matter. So I think cholesterols and doing an LDL cholesterol and HDL cholesterol, some people do particle size, which I think you can comment on as well. But I think a basic screening test is getting your cholesterol levels. There are new guidelines, not without controversy, that have been published by the American College of Cardiology and the American Heart Association. Clearly, if your LDL cholesterol is greater than 190, which is considered quite high, they recommend the immediate institution of a statin, which is a cholesterol-lowering drug in moderate levels. And then there's a whole algorithm that we use when we use that risk calculator. If in fact over a 10-year period you fall into a 6 to 7% risk of having either a heart attack or a stroke, using the numbers of a particular patient, then we would recommend the patient being placed on a statin, which is a cholesterol-lowering drug. I think, though, that a doctor has to look at the whole picture.
Right.
And it's just not a number. It's the other risk factors, whether they're smoking, whether they're diabetic, whether they have a family history, whether they have high blood pressure. And they are all additive factors. They don't act they're not independent of each other. So consequently, if I see a patient that doesn't necessarily meet the criteria that the ACC and the AHA suggest for treatment. If they have these other risk factors, however, I am more prone to treat. So I'm fairly aggressive in treating cholesterols for primary prevention.
Primary prevention being you haven't had a heart attack yet.
You've not had a heart attack,
so people know
which
that,
is very different than secondary prevention. The horse is already out of the barn.
You've had the heart attack.
You've had the heart attack, you've sustained...
Or the stroke.
Or the stroke, which is potentially worse.
Or peripheral vascular disease.
Or peripheral vascular disease, or you've had an aneurysm that you've had an operation for. There's no question that secondary prevention, everybody agrees. Everybody needs to be treated extraordinarily aggressively with a statin, to the point that their LDL levels, which is their bad cholesterol, is as low as possible. And contrary to popular belief, there is no such thing as an LDL that's too low.
Well, the hunter-gatherers have LDLs of 40.
Right, exactly,
So,
and there you go. Primary prevention tends to be a little bit more controversial. However, there is a plethora of information and studies that have been done through the years that have clearly demonstrated that if your LDL cholesterol is low, and we're talking about significantly under 100, the chances of you having a heart attack is reduced by at least 35 to 40%. 35 to 40% is fairly significant.
That's a lot. It's
Yeah.
a lot of patients. It's a lot of reduction.
It's a lot of reduction.
I use the particle number because an LDL number can have a lot of LDL little particles or a few big particles to define what the particle number is. For a typical woman who has an LDL of, let's say, 140, HDL of 70, 60, and people say, oh, well, the HDL is protective. So for those people, I like to use the particle number. If they have a low particle number of LDL, I feel safer than if they have a high particle number.
I think that's probably very true, and I think that's very accurate. I think that as a society, because many people have a reticence to be placed on a drug, there's an extraordinary reticence to be placed on a statin. And quite frankly, I find that more so amongst my Greek patients, to be honest with you, that they think they're going to develop liver dysfunction, kidney dysfunction, myalgias, and all sorts of myopathies, all sorts of...
They're very safe.
These are probably one of the safest classes of drugs that have been developed, and really, in our lifetimes, very few drugs have made such an impact. This is a big impact class of drugs that have really saved lives. We are doing less bypasses, we are doing less angioplasties, we are seeing less heart attacks.
Because of statins.
Because of these drugs. So these drugs are very, very effective.
When patients tell me they've read the side effects of statins, I tell them, well, that's fine, but I'd like you to read the benefits of statins.
Absolutely.
Lipid lowering, plaque passivation, anti-inflammatory within the artery. Let's talk a little bit about what statins do besides lower your LDL.
Well, those are what we call the pleiotropic effects of the drug, another good Greek term. There's no question that we know that when an artery closes, it's just not cholesterol, but we know it's that mushy cholesterol in that plaque that can rupture, and it's that rupture which can be brought on by inflammation, that thereupon can cause a whole bunch of mediators to be elaborated in the vessel wall that can very quickly cause a blood clot to form. So it's the plaque plus the inflammation plus some vasoreactivity, right, plus thrombus, which is blood clot. The combination of all of those things, which can happen very rapidly.
Because plaques are active. They're
right.
not, yeah.
This is an active thing. This is a vasoactive thing. This is a dynamic process. This is not a static process. So when we treat this disease, we treat it at all levels. We treat the cholesterol, we treat the vasoreactivity to some extent, we treat the platelets. The statins have lipid lowering capacity, which means that the propensity to have a plaque that's full of mushy cholesterol is lessened. They have anti-inflammatory properties, which thereby lessen the inflammation which can cause that plaque to rupture. And they have antithrombotic properties as well, which decrease the incidence of a clot being formed on top of that plaque, which therefore closes that vessel and causes the heart attack. So I have to say, these drugs are very effective, and as you said, very safe.
Very safe, and people should also read the benefits before they focus on the side effects. Now let's talk about a common side effect. We'll get back to diagnosis and treatment. The myalgias from statins, because you and I both give CoQ10
for
for that. It works for the most part.
There's no question that in patients that have had that problem, CoQ10 does work. I've had a very...
How many milligrams? 300?
Yes, 300. I've also noted that in patients that have had problems, check their vitamin D levels, because if the vitamin D levels are low, that can also add to the potential problem, and very frequently repleting vitamin D helps. Now, you know and I know that we see full-blown myopathy very rarely.
Yeah, there are those few patients that genetically can't tolerate it.
Right, there are those
very
few
rare.
patients, and there are drugs that are being developed, and I suspect that will be approved in the next year or so that will address those folks. That'll be very potent cholesterol-lowering drugs without those potential problems. But a lot of people just have arthritis, and they think it's the statin. It's really very rare that we have to stop the statin.
It's rare. And the CoQ10 is lipid soluble. People
Yes.
need to take it with some healthy fat, either a fish oil or a vitamin E pill, just to make it emulsify that vitamin E is beneficial, or olive oil or avocado.
Right.
It needs some kind of oil or fat to be absorbed.
So when we look at all the stuff that's out there, and I use stuff because there's a lot of stuff out there. You can go to a vitamin store and stock up on all the stuff. Of all that stuff, the only thing really that I use and I think is very effective is CoQ10. I think CoQ10 is very effective. And we're even starting to use it in heart failure now in some patients too. There's some suggestion that its ability to affect favorably the energy stores of the heart. Mitochondrial stores can be very important. So I think it's a very useful drug.
There's a reason it's in our muscles.
Right.
Right. We just have to get it in there.
Right.
Right. So back to diagnosis, back to screening. I mean, insurance companies don't allow us to do many things without symptoms, but we can do a lipid test. What about a stress test or
a standard stress test can be still a first line. However, in females it may not be, as you know, because we can get a false positive on a standard stress test. Which means that your EKG can change with a stress test, but it doesn't necessarily mean that you have any significant blockage. So what I usually like to do is I usually like to couple the stress test with an imaging modality. And one of the safest imaging modalities is a sonogram, an echocardiogram, that you can do a stress test and an echocardiogram at the same time. Under normal circumstances, in the absence of any significant heart disease, your heart should really augment when you're exercising. All those walls should really beef up and really pump very strongly. That's the normal reaction. If they don't, or if a portion of the heart is relatively weak to the rest of the heart, that suggests that there may be a blockage in an artery that's feeding that part of the heart muscle. So a stress coupled with an echocardiogram, I think, can be very effective as a screening tool. We also use stress testing with nuclear imaging. There's no question that it can be very effective in diagnosing heart disease. There is a radiation component to it. We do a fair amount of it, but I am mindful as to how many I would do in a particular patient. And then some of the newer technologies I find very effective, and CT angiography, which is a CAT scan of the arteries of the heart, can actually show you whether it's soft plaque, whether it's hard plaque, but more importantly, it can show you whether it's a 10%, 20%, 30%, 40% lesion before a patient develops clinically significant heart disease. Because for a stress test to be positive,
you have to have something.
You have to have a 70% blockage. So, you know, the take-home message for many of my patients is, well, I had a negative stress test, there's nothing wrong with me. No. A negative stress test means that you don't have significant heart disease. It doesn't necessarily mean that you have no heart disease.
Right. You could have mild to moderate disease and still do well on your stress test.
You can have a 40% blockage, and as we discussed before, it's that 40% mushy blockage that we're worried about that can ultimately rupture and cause a problem. So a stress test is helpful, but it's not the end-all. So I find CT angiography, a CAT scan, very, very helpful. Unfortunately, not every insurance company has had the wisdom to cover it. But I think it's a very, very useful tool, especially in the patient with that falls into that intermediate risk group range that has the cholesterol of 230, 240, and I'm not sure whether I should treat them aggressively or not. If I do a CT angio and I see that they have soft plaque, they're getting treated very aggressively.
They're getting treated like a secondary prevention,
Exactly.
first, even though they're primary prevention.
Exactly.
I tell my patients stress test is a supply and demand test.
Right.
So if you can't exercise a long time, that's also decreases the information you get from the test. So if you're not fit and you finish the stress test quickly, you're not going to pick up a significant lesion. So,
Absolutely.
So that's the other thing. It's supply and demand. So basically, it tells you for whatever you've done on your treadmill, your blood supply is adequate.
Right.
So,
But doesn't tell you more than that.
right. So if you've done 12 minutes, you probably have a good heart. But
If you've done 12 minutes, you statistically fall into a good category.
so yeah, so it's supply and demand. So you really have to.
But I think
demand
the
a lot.
take-home message is it's a useful test.
Very useful. I agree.
However, it's not necessarily the ultimate test. And then ultimately we have the angiogram, which is a relatively invasive procedure, which we would do in a patient with a grossly abnormal stress test or an abnormal CT angiogram.
Or a compelling story.
Or a compelling story. There's very frequently, you're right, there are people that I have bypassed the stress test that I've been so convinced they've had critical coronary disease that we've gone directly
to the angiogram.
to the angiogram.
And they're safe. I tell my patients the technology is so good now that angiograms are pretty safe.
In competent hands, and I must say at NYU and in all the university centers in New York and major hospitals, it is a very safe exam, and it remains the litmus test for how we do and what we will do after, whether it be a stent or whether it be open heart surgery or whether it would be the continuation of medical therapy.
That's true. So stent, bypass, medical therapy are three options afterwards. Let's talk a little bit about cardiac rehab. You and I both feel strongly about cardiac rehab and how beneficial it is. Why?
Well, there's no question that we know that conditioning and your aerobic capacity.
Well, let's tell patients people what cardiac rehab is.
Cardiac rehab is a exercise program. It's actually an exercise gym for cardiac patients.
Right. Monitored setting.
It's a monitored setting, and that's the great advantage. Everybody gets an individualized exercise prescription, which was based on your stress test, because we want to see what you can do, because not everybody starts at the same level. And it's safe because you're not permitted, and you know, these are the disasters we see. The guy that's obese and diabetic and hypertensive that goes sees his doctor, and his doctor says gets into shape, and he decides that on day one he's going to try to run the mile that he hasn't run in 20 years. And he has a horrible event. Or the guy that goes out shoveling snow when he hasn't shoveled snow in 2 years, or we're having a bad winter. So everybody starts at a different level. And most insurance companies will pay for it in a patient that's either had a heart attack, had a stent, or had open heart surgery. The insurance companies will pay.
Or abnormal stress test.
Or an abnormal stress test. Will pay for several months of
36 sessions.
36
That's
sessions.
Medicare. I don't know about the
Okay.
insurance.
But they will pay, and I think it's very worthwhile.
And patients definitely go in and improve their stamina. People who complete cardiac rehab increase their treadmill time on the
But not only that, they're being counseled by a nutritionist. They're talking about risk factor modification, all things which are very important. And there's a communal setting, which are seeing other people with the same disease progressing very well. It's interesting. Most of my patients that have done cardiac rehab have re-upped and paid for them themselves after the session was up and continue it indefinitely.
So what does cardiac rehab do? It obviously makes your arteries more supple, it calls in reserve. Let's talk a little bit about what it actually does.
Well, there's no question that exercise can favorably affect weight loss, which we know is important. It can lower your blood pressure, which we know is a risk factor. If you are a diabetic, it can very significantly lower your A1Cs, independent of all the other modalities that we use. So, in essence, an organized exercise program favorably impacts all the risk factors that have gotten you to where you are.
It also makes you use your cardiac reserve.
Absolutely.
Makes you use little blood vessels in the heart that ordinarily you don't call upon.
Right, and those little blood vessels in the heart that you ordinarily don't call upon are the ones that could save your life.
Right, right. So very important.
Very important.
We can't, I mean, a lot of people forget to remind their patients to apply for cardiac rehab after a stent or after a positive stress test.
And there are very good cardiac rehab. There are not a lot of them around, but there are very good cardiac rehab programs out on Long Island and in Queens, as well as there are in the city. And I think it's something that someone should discuss with their cardiologist, certainly if they've had an abnormal stress test or have had a procedure, or certainly if they've had a heart attack.
Now let's talk about diet. You know, I tell my patients everything in moderation, but there's definitely an advantage to having the Mediterranean Greek diet. So diet is important in preventing heart disease. Fruits, vegetables, the DASH diet, Mediterranean diet. Let's talk a little bit about that. What do you tell your patients?
I tell my patients the Mediterranean diet is an ideal diet. Plenty of grains, fruits, vegetables. Fish, all the fish they want. You know, I try to construct a diet that's not a punitive diet. I tell them that they can have the occasional steak. Right. You know, it's not meant to be, and they can have the occasional lamb, my Greek patients.
Every Easter.
Right, every Easter, and they can even have some kokoretsi on Easter, although I cringe when I think about it. But
yes, but it's delicious.
It is delicious, and we let them have it with a little red wine, which is also helpful. But diet is important. In my diabetic patients, you know, we try to focus on a lower carb diet. It's interesting that a lot of diabetics don't even know anything about carb counting, which is important. But we are blessed that we have a great Greek diet that with little virgin olive oil and chorta and fish, we can go a long way.
So get a Greek cookbook.
Get a Greek cookbook. I think that's a great, a good, simple cookbook. And being the father of all these females, my girls they are devouring Greek cookbooks now, and they're cooking these great Greek meals for us.
I know, they're great. And all these Greek restaurants have popped up in the city that are wonderful.
And Greek yogurt.
And Greek yogurt. Yeah. And everyone's copied us.
Yes, everybody's copied us.
Yes. So diet's important, and the DASH diet is interesting. People who go on the DASH diet, which is not necessarily a weight loss diet, it's a blood pressure lowering diet, which in a nutshell, 3 fruits, 5 vegetables a day, I tell my patients, is also beneficial in lowering blood pressure.
No question. And, you know, very frequently, if we do a careful, and unfortunately the structure of modern medicine today sometimes precludes us from having these very prolonged dietary discussions with our patients, which is unfortunate because we should.
There's no time. I know there's no time.
But there's no question that if you take a careful dietary history on a patient that's hypertensive and you go through what you just went through, and if they just follow that, they can lower their blood pressure sometimes independent of even starting them on any medication. Yeah. Or if they even lower their alcohol consumption. I mean, we know that...
didn't touch upon alcohol.
We know that a little alcohol or moderate amounts of alcohol are good, but excessive alcohol, very frequently, you know, we see plenty of business people that have the martini lunch or the 2 martini lunch, and then they come home and have a scotch before. If they just cut down their alcohol consumption, their blood pressure will come down.
You tip the pendulum if you go about 2 drinks. And it raises your blood pressure, raises your triglycerides, and it's caloric.
Right. Calories.
And it's a lot of calories.
Calories.
Yeah. It's like having dessert.
Right. Absolutely.
But it just doesn't feel that way.
So I think that diet is, you know, lifestyle. Let's face it, lifestyle is everything.
And then always, when you're desperate, everything in moderation.
Right.
Just be moderate. And activity is important. I tell my patients, if you can't go to the gym, if you don't like it, do 10,000 steps a day. Get yourself a Fitbit or a Jawbone or whatever they're selling now. And
your iPhone has an app. And the reality is 10,000 steps a day is about 5, believe it or not, it's about 5 miles, and it's not that difficult.
No, you have to be mindful.
You have to be mindful of it, but it's not, you know, it's not punishing.
No, you could do it over hours.
Absolutely.
And I noticed the people that I stress on the treadmill, the ones that actually do 10,000 steps a day, are as fit as the gym goers.
No question.
It's interesting.
No question.
Yeah.
No question. So it doesn't take a lot, but it is a change in lifestyle.
So we've covered a lot of information today. So let's summarize it for our viewers.
Okay, we're going to summarize. It's a complicated topic, a lot of information. We've had a technological explosion. We've had great drugs. But what we really want to emphasize is lifestyle changes. So we don't get to the technological explosion, and we don't get necessarily to the drugs if we can avoid them. But if we have to, we will. And that is, if you're smoking, by all means, stop smoking because it is deadly. If you're overweight, we need to get you into an exercise program. If you're diabetic, an exercise program is the greatest thing in the world. So I think we're going to focus on a good, healthy, Mediterranean, Greek diet and an exercise program that doesn't take much, really, to achieve. And really, from a cardiovascular perspective, if you can do 20 to 30 minutes 3 to 4 times a week of aerobic exercise, that's sufficient. And watch what you consume and decrease your stress.
Please join us again next week on Women's Health Watch. I was your host, Dr. Eva Kosta. See you all again next week on New Greek TV.
More than 8 million people live right here. 27,000 of us for every square mile. That's a lot of people. What makes this city such an attraction? What makes this place so cool? We take pride in saying, I'm a New Yorker. And that's the way it's always been. One thing we've all learned in recent times is that no matter what life throws at us, we face it together. And we always come through, stronger than before. We are, for the most part, good people. We come to the aid of others, willing to lend a helping hand because we care. Even though we sometimes get the impression we don't. At NYU Langone, we're here to care for our fellow New Yorkers and for everyone who needs us. That's what we do. That's what we love to do.